Today, we will talk about the WHO system for reporting lung cytopathology. So this is the agenda of my talk. We will talk about the role of cytopathology in lung, the reporting systems, the systems categories, the structure of the report, and finally, the role of ancillary techniques.
So let's start with the role of cytopathology in lung. So we used lung cytology, especially today, for the diagnosis of lung cancer in general, but also for the detection of infections and in some special hospitals for the evaluation of interstitial disease of the lung. Lung cytology has one peculiarity because it's not only one type of cytology. So we can sampling lung lesions in the different ways. For example, using bronchoalveolar lavage or bronchial wash, using fine needle aspiration cytology, bronchial brushing, or in the old times, we can use the cytology of the sputum. The problem is that the sensitivity and specificity of each of one of these cytological methods are different. And this depends not only of the methodology of sampling, but also of the location of the lesion. This is a table that will be presented in the book. It's made by Dr. Moderator. And then you have the sensitivity and specificity of each methodology. And as you can see, for example, bronchoalveolar lavage has a very low sensitivity to detect lung cancer. It's the opposite to fine needle aspiration cytology. Transbronchial or transthoracic, they have high sensitivity and high specificity to detect lung cancer. So these different methodologies have some implication in the risk of malignancy in the different categories of the system, as I will show later. One methodology used with more and more frequency in the different hospitals is the endobronchial ultrasound guided FFNA. It is a FNA performed through the bronchial wall using the bronchoscope and the real-time ultrasound guidance. And we can sampling not only lung central lesions, but also mediastinum and also lymph nodes, peritracheal, peribronchial lymph nodes. And when we use this invasive methodology, as when we use transthoracic FNA, it's advisable to have rapid on-site evaluation. Because in the rapid on-site evaluation, we can not only to say to the clinician, okay, I have material, but also I can split the material for the different ancillary techniques that eventually I will need in according the type of pathology that I'm looking. For example, if I'm looking at a lung, non-small cell lung cancer, I know that probably I will need immuno and molecular. If I'm looking at lymphoid proliferation, probably I will need flow cytometry. And during the rows, I can separate this material according to the further studies that could be needed. Okay, knowing our role in lung pathology, let's move to the reporting systems. So we know that there are many advantages to use a standardized terminology in pathology. Why? Because this standardized terminology unifies reporting of disease categories, providing a well-defined diagnostic criteria and a well-defined risk of malignancy, reduce the inter-observer variability, improves intra-observer reproducibility, better aligns patient management options with interpretations, and also in the end improves patient care. This is one of the first systems used to reporting lung cytology. It was used by Dr. Papanicolaou, and it was published in Cancer Research in 1966. And they divide the lung cytology in 4 categories: negative, ambiguous, suspect, and positive. After this initial classification of Papanicolaou, many years passed without a reporting system for lung, till to appear the Papanicolaou Society guidelines for lung cytology. So they divide in non-diagnostic, negative for malignancy, atypical, neoplastic, benign neoplasias and low-grade cancer, suspicious for malignancy, and malignant. And more recently, and it was published last year in Acta Cytologica, a new system proposed by the Japanese Lung Cancer Society and Japanese Society of Cytology. And this system, the Japanese system, first divide the cases in adequate and inadequate, and then in the second step, just for the adequate sample, they divide in negative for malignancy, atypical, suspicious, and malignant. In fact, none of them nomenclatures are truly international. And this is one of the reasons that in 2020, the International Academy of Cytology signed a memorandum of understanding with the IARC and the WHO to cover, at least in the beginning, 4 systems to be produced in the 2-3 years. Lung, that we are talking today, pancreatobiliary, that was already showed by Dr. Pittman, and lymph node and soft tissue that we will present in future webinars. There was a key agreement that's to promote the use of standardized nomenclature and diagnostic criteria in cytopathology in the worldwide way, and utilize the cancer cytopathology expertise to develop international reporting system. Very important is the link, direct link between cytopathology and the website of the WHO, the WHO tumor classification, that's so-called blue books, bringing a dynamical practical link between cytopathology and surgical pathology. For me, this is one of the most important results of this understanding, because today it's starting the way that the pathologists are looking for cytopathology became to be different. So classical pathologists in the lung cancer area now are cooperating with our book and are making link between the 2 classifications. And this is quite important. And I can give you news to you that because of this, we, the ERCC, the international agents that are providing standardized reports for cancer in the world, recently they came to the IAC asking if IAC was not to join them to propose standard reports for cytopathology in cancer cases. We will start by the lung, but then we will go to the other systems. This is a great development for cytology, and especially the way that the pathologists, the classical, traditional, surgical pathologists are looking for cytopathology. These are the 4 books of WHO that are under development. These are the standing committee, the series editors that already Massimo mentioned in the beginning, and then the Dr. Ian Cree, that's the head of the WHO book classification, is the president of this standing committee. Which categories? So there are 5 diagnostic categories. So insufficient, inadequate, non-diagnostic, benign, atypical, suspicious for malignancy, and malignant. They are not different from the current reporting practices, but for each category, we provide a criteria and the management for these categories. These result in the clear communication with the clinicians and of course, an appropriate management and follow-up. Each category has a risk of malignancy that is based on the recent literature, but for sure should be refined as experience increases and may vary between individual practices. The risk of malignancy from these different categories were published in these four papers. And look, there are very few papers because the nomenclatures are new, and there are very few papers studying this. We need more and more papers providing risk of malignancy for these different categories. Okay, how is the book? The book will be like this that I'm showing to you. This is the website that we will have the access, as many of you know, for the Blue Books. We will have for our reporting systems with the different contents. And who are the authors and co-authors of these different chapters and sub-chapters? They were cytopathologists around the world that were chosen because of their publication records and their experience in lung cytopathology. So there are authors from everywhere, from Europe, America, Asia, Australia, Africa. So this is a wide participation, as we saw in the Blue Books. Let's go to the categories. The first category is insufficient, inadequate, non-diagnostic. This is the category that provides no useful diagnostic information in a specific clinical context. Why? Because the cellularity is insufficient, or because there's artifacts, hemorrhage, bad preservation of the cells. As in other reporter systems, any atypia should be reported as such and put under the atypical or suspicious category. The incidence is around 16%, but there are few studies, and the reported risk of malignancy is quite variable between 20 to 40%, but there are few studies in the different using different samples. One of the problems of this category is that there is no criteria what is adequate in lung cytology. There is no criteria of adequacy. There are some ones. For example, for sputum, we know since long years that the sputum should include at least some alveolar macrophages. And this was quite well known. In bronchial brush should include abundant bronchial epithelial cells, and macrophages may be present. In bronchial wash should include identified alveolar macrophages for ball, more than 10 alveolar macrophages per high power field. In fine needle aspiration biopsy, there is no definitive criteria. Of course, if I'm looking the lung, I need to have some macrophages. If I look lymph nodes, for example, I need to have at least more than 40 lymphocytes in the area of highest cellularity. But as you can see, these criteria are not so rigid, could be variable. And this is one of the problems to say, okay, this case is insufficient, inadequate, and non-diagnostic. But we can say an inadequate, insufficient, non-diagnostic specimen, as you see this in the book, is a specimen with no pathologic infectious microorganism or virus, no abundance of inflammatory cells, no granulomatosis inflammation, no diagnostic matrix or acellular material, no atypia, or a sputum devoid of any pulmonary macrophage. But for me, the most important in this category is these scenarios that we need to clarify, and that we don't have enough studies yet to clarify this. One thing is that in your left side, we have a mass, well-defined. Fine needle aspiration was performed. The needle was inside the mass. You were there, okay, doing rows. And then we look your slides and there is just some bronchial cells or just some cartilage or just some macrophages. This is clear insufficient material because the lesion was there and you are not seeing any pathologic alterations. So you can really say this is an insufficient or non-diagnostic material. But we know that in the practice, most of you are in the lab receiving slides with the clinical information. And so imagine you receive a bronchial wash saying, okay, this is a 68-year-old man with a pulmonary lesion or nodule, and you see only benign components, bronchial cells, macrophages. This is non-diagnostic, or you should report as benign cytology. So we can discuss this for a long time because inside our group, we don't have a consensus about this. Why? Because we need to see what happened with the patients that I call benign and the clinician informed that it is a lesion in the lung. What's the risk of malignancy of this benign? Okay, so this is a problem that it is not yet solved, how to call this scenario in your right side. The category benign is a category that demonstrates unequivocal benign cytopathology features, which may or may not be diagnosed of a specific process or benign neoplasia. The incidence is around 50%. The risk of malignancy is variable between 20, 40, 80%, almost the same of the non-diagnostic. So it's interesting. And the main causes are inflammatory, infectious, benign. And the management of these situations always correlate with the clinical image of microbiology. And if this confirmed benign, routine follow-up 3 to 6 months. If there is no correlation, consider a new sample. So here you have beautiful examples of a benign cytology of the lung in infectious disease, so tuberculosis with the Zil-Nielsen positive, an aspergillosis, or an inclusion from a cytomegalovirus. All these pictures are from the book. Or you have a situation that you have a very well-defined lesion in X-ray, unique lesion in the asymptomatic, many times patients, we do a fine needle aspiration, and then you have a cartilage, stroma, and bronchial benign cells. This is a typical cytology of a pulmonary hamartoma, and this is in the category of benign. Let's move to the atypical. What means atypical? Atypical indicates that the cell morphological abnormalities are present in the specimen that are sufficiently well developed to preclude a definitive diagnosis of negative, but at the same time are insufficient to call suspicious. The incidence should be low, and this is around 5%, and the risk of malignancy is between 40 to 60%. The main causes for atypical is reactive changes like metaplasia, hyperplasia, or infectious, or post-therapy changes. The management is the same, correlate with the clinical image microbiology. If all are benign, repeat in case of exfoliative cytology, or follow up at 3 to 6 months after a multidisciplinary meeting in case of fine needle aspiration. If there is suspicious in the clinic or in the image, we need to immediately repeat the cytology with or without core needle biopsy. Very important, ciliated cells of the lung could be very reactive, like you are seeing here Sometimes you cannot clearly see the chromatin, but then you change the micrometer in your microscope, and then you see cilia. And this means this is a benign reactive cytology. Recently, in the end of 2021, it was published this paper by Dr. Leifeld about atypia in pulmonary cytology. And then you can see several situations here that can provide atypical cells in cytology in lung. For example, squamous metaplasia with some atypical nuclei, epithelioid cells with clear formed cytoplasm that sometimes the very well differentiated adenocarcinoma entering the differential diagnosis, or epithelial or reserve cells reactive that can be appears in clusters or in in overlapping of the nuclei. So another kind of atypia is hyperplasia of the basal cells in the bronchial epithelium. So you must not confound with the small cell carcinoma. So here the chromatin is more dark, it's not salt and pepper, there is no necrosis, there is no mitosis. Very, very difficult sometimes is to do the distinction between the hyperplasia of pneumocytes in lung parenchymal injury on cytology, where the cells could be very atypical, like this one with huge nucleoli, and the differential diagnosis with adenocarcinoma could be very difficult. So one tip here is that in a patient with the diffuse lung lesions, be very careful. Be very careful to call these carcinoma. So look this case. This is a case that we had last year. Is a patient with a Cyscop2 infection. And in Cyscop2 infection, the reaction in the alveolar epithelium are very prominent. And as you can see here in the cytology, in the bronchial lavage of this patient, we have a very, very atypical cells. But the patient has diffuse lesions around the lung. After chemotherapy or radiotherapy, especially, the cells can be atypical, can be bigger, larger, nucleoli is very large, cytoplasm is very also large, and you have the clinical history that the patient had previous treatment. And multinucleation can appear in these patients, including intranuclei pseudo-inclusion, as you can see here. The other category is suspicious for malignancy. So this category applies to samples that demonstrate some features suggestive of malignancy, but insufficient, either in number or quality, to make a diagnosis of malignancy. The incidence is around 5%. The risk of malignancy is higher than the risk of malignancy of atypia, 60 to 9%. The main causes could be the intrinsic characteristics of the tumor, or extreme reactive atypia, or problem in the sampling, and you have very few cells. We need to correlate with the clinical image and microbiology, and all these cases should be discussed with the clinicians. Because if there is no correlation, that lesion is malignant, we need to repeat FFNA, especially with the rows with or without core needle biopsy. So here are one examples of suspicions of malignancy with a mesonucleosis very prominent, or with increase in the nucleocytoplasmic ratio. And then this is a case that you can see in the book. In a fine needle aspiration, the patient has only this group of cells with the nucleoli. So that was performed a cell block, and then just this only block of cells, very atypical, looks like cilia here. But then the case was called suspicious for malignancy. The patient was resampling, and in the end, it was an adenocarcinoma. Finally, the malignant category. A specimen classified as malignant demonstrate unequivocal cytomorphological features for malignancy. An attempt should be made to further subclassify the neoplasm based on cytomorphology and, if necessary, by ancillary tests. The incidence is around 20%, and there are few studies. The reported risk of malignancy is between 9 to 100%. And the main causes are primary and second malignancies. So we cytopathologists have a very important role in lung cancer. We know that lung cancer is the second most frequent cancer in the world and with a higher mortality. 70% of the cases of lung cancer are still diagnosed in the advanced stage. So the only material that we have is a small biopsy or cytology. Then, so we need to provide diagnosis. We need to subtype, because today is not important only distinguish small cell lung cancer and non-small cell lung cancer. And the subtype of small cell, non-small cell lung cancer has clinical relevance. And then in the end, we are deeply involved with the molecular tests that are fundamental for the tailored therapy. So this is the frequency of the different histological subtypes of lung cancer. So the most frequent is adenocarcinoma, 40%, followed by the squamous cell carcinoma, 30%, and the small cell lung carcinoma, 15%, and then the other more rare. The morphological aspects of each subtype are very well defined. So a good morphologist, cytopathologist, look at adenocarcinoma, knows that they have big nuclei, nucleoli prominent, sometimes mucus in the cytoplasm. When you look for a squamous cell carcinoma, they have keratinization in many cases. You have this pycnoclinic nuclei, smooth chromatin, very well defined borders in the cells. If you look for a small cell carcinoma, you have the salt and pepper, chromatin, dirty background, molding. So it is quite classic. Okay, here I will show some figures of the adenocarcinoma that are published in the book. So you see sometimes are very clear with the small acini or mucus in the cytoplasm. Sometimes there are big groups of cells, as you can see here. Mucus intracytoplasmatic and micropapillary. So different subtypes. The squamous cell carcinoma, this is the classical keratinized type. So easily to recognize in Papa Nicolau stain, in Giemsa stain, or in cell blocks. But remember that you have a non-keratinizing squamous cell carcinoma where the nucleoli may be prominent, so can bring some problems with the differential with adenocarcinoma. Cells can be spindle, oval, and can be in sheets like you can see here, but without any keratinization. So classical necrosis can be seen. Squamous cell carcinoma frequently has a central area of cavitation because of necrosis. You have spindle cells, but then you have the basaloid subtype that enter in the differential diagnosis with the small cell cancer. There are clearly criteria to distinguish adenocarcinoma from the squamous cell carcinoma. You have this in all the books, and they are very clear. We teach to our residents, and looks like easy, but this is not the real life many times. So as an older professor of mine said, the disease don't read the books. So sometimes the disease has peculiarities, the variations that are not in the book. And this is true. Look for this study that was recently published in the journal Thoracic Oncology. So it was made a survey, among 13 expert cytopathologists to subtype 120 cases of non-small cell lung cancer. just adenocarcinoma or squamous or non-small cell lung cancer. So I am one of these cytopathologists that participate in this study. We circulate and ask to say, okay, say this is adeno or squamous. That looks like easy. They are all dedicated to the pathology of the lung. But look, we were totally concordant in 60% of the cases. So means that in 40% of the cases, there was a problem. So, or misclassification, call adeno and it was squamous, or we say, okay, we cannot classify. Here you can see this. Look, the adenocarcinoma, the concordance for the diagnosis of adenocarcinoma, it was 60%. The concordance for the squamous cell carcinoma drops to 45%. So it's not so easy in the real life sometimes to make this distinction. And this is the reason, because we need to apply sometimes immunohistochemistry. And which kind of markers? So especially these two markers signed in red, TTF1 for adenocarcinoma and P40 for squamous cell carcinoma. They are markers of the nuclei. So in cytology, sometimes during the smears, cytoplasm is lost. So markers in the nuclei, especially for smears, not for cell blocks, but for smears, works very well. And then you have the second line markers, for example, napsin A for adenocarcinoma and cytokeratin 5/6 for squamous cell carcinoma. Important, look for the clone. So for TTF1, this clone, AG7G31, is more specific, although less sensitive. Look at this case. So this is a transbronchial fine needle aspiration. You have a cell block. You have the cells in your right side. So how do you classify? Adeno or squamous? Okay. Sometimes looks like that the cytoplasm is a little bit red, maybe some keratinization, nucleoli sometimes looks like visible, difficult. So the immunohistochemistry in cell block showed that this is in the squamous cell carcinoma. P40 was positive, strongly positive. TTF1 was negative, and here you can see an internal control. Other case, now look here, prominent nucleoline in GIMS stain in the cytoplasm looks like more dense, but in the end is an adenocarcinoma, TTF1 positive, P40 negative. Small cell carcinoma. So this is the classical criteria that most of you knows: molding between the nuclei, dirty background, salt and pepper chromatin. When you have a cell block, sometimes you have this crushing artifact that you saw also in the small biopsies. Here you see the molding. Sometimes the small cells are not so small, as you can see here, but they are TTF1 positive, and in this case, chromogranin positive. It is possible to diagnose carcinoid in cytology. It looks like that's possible, especially when we have this clinical presentation, this morphological presentation. So you have isolated single cells with a round nuclei. Chromatin is look like the small cell carcinoma, salt and pepper, but there is no necrosis, no molding, no mitosis. And we have also a variant of the carcinoid that is spindle cell subtype. Here you can see some figures that are from the book. Look, sometimes they looks like inclusive plasma cells, you know, because of this distribution of the chromatin, and carcinoids sometimes enter in the differential diagnosis of the hematopoietic neoplasia. Here's the spindle cell, and this is the cell block. What about large cell neuroendocrine carcinoma? Large cell neuroendocrine carcinoma is a high-grade non-small cell lung cancer with neuroendocrine morphology and neuroendocrine marker expression. There are many key diagnostic features of these tumors. The cells are larger than usually what is larger, more than 3 lymphocytes in diameter with abundant cytoplasm. There are molding, there are chromatin with the salt and pepper, there are necrosis, there are mitosis. One of the big differences between large cell neuroendocrine carcinoma and small cell neuroendocrine, besides the size of the cell, is the presence of nucleoli that enter in this group and sometimes cause trouble to distinguish, for example, from adenocarcinoma. Here you see some examples, the big cells, and then the cell block and the synaptophysin positive. This is a table from the book that we will see the main features of the 4 different neuroendocrine tumors. In cytology, is very problematic to distinguish typical or atypical carcinoid. So it's better in this case to say that's a neuroendocrine neoplasia, no high grade. That is, we rule out a small cell and large cell neuroendocrine carcinoma, and then could be a carcinoid, typical or atypical. This classification, we will need the surgical specimen. How is the structure of our report? So the standardized cytopathology report needs to have a demographic information, like all our reports, name of the patient, birth, address, etc., etc. The type of specimen, and in lung, this is quite important. Say if it's a sputum, bronchial wash, bronchial lavage, bronchial brush, FNA, if it is EBUS or transthoracic. The clinical and imaging information, the site, the size, which kind of imaging feature, if there is previous cytology or histology, the category, for example, malignant, and then the diagnosis, example, cytological findings of small cell carcinoma. The reporting system category is always a name, never a number. Doesn't exist the category 1, 2, 3, 4. And the diagnosis should be a specific diagnosis or at least a differential diagnosis. So it's this, but I cannot rule out that without ancillary techniques or new sampling, for example. What's the role of ancillary techniques? So patient with a small lesion in the lung, I have cytology. It's a known small cell lung cancer. Okay. So if it is a known small cell lung cancer, I need to say this is an adenocarcinoma or this is a squamous cell carcinoma. If it is a small cell, I do neuroendocrine markers and I classify. If it's a non-small cell, I do TTF1 P40, and then I can classify this is an adenocarcinoma, then a squamous cell carcinoma. But besides subtyping is important, saving tissue for molecular studies at this moment is even more important. So don't waste your small biopsy or small cytology sample to doing a large panel of immunohistochemistry. So save this tissue, because this is a precious tissue to be studied by molecular that can drive the treatment of this patient. So we saw before, if you have a classical morphology, you don't need to confirm this with immunocytochemistry. So if you have a squamous cell carcinoma like this one, or an adenocarcinoma like this one, this is your diagnosis. And then if the patient needs molecular studies, the patient will have this material for to do the studies. Don't do immuno if it is not necessary. And if it is necessary, use a short panel. As I told you, preferentially P40, because The sensitivity, the specificity of P40 for squamous cell carcinoma is 97% against 69 from P63. We don't use anymore P63 in lung, we use P40. If one of this primary, TTF1 or P40 was negative, I can apply a second marker, for example, napsin in this case, to subclassify. But don't do a large panel with the different cytokeratins, etc., especially if the clinical hypothesis is a primary lung tumor. Another point, look, I'm showing this cytology to you. So unfortunately here, we cannot do more interactivity to ask you, but you see two aspects of the smears and the cell block. Some cell block looks like more bright tendency of to see the cytoplasm as keratinized. But this is an adenocarcinoma. This is TTF1. So do not trust in this squamoid appearance in cell blocks, especially if the cell blocks were fixed with alcohol-based fixatives. They give this aspect of squamoid. No? So don't trust using immunohistochemistry if there is no clear differentiation. Okay, if I have a specimen with lung cancer, I show you. If it is neuroendocrine, it's here. If it's non-neuroendocrine, it's here. If it is an adenocarcinoma, we need molecular studies. If it is a squamous carcinoma, we need at least PD-L1 that we need also in adenocarcinoma. If it is a secondary neoplasia, in general, we have a clinic. So patient has a previous cancer and now a pulmonary nodule, but sometimes not. So we can apply the classical panels that we have in this table, and this table will be in the book also with the different panels that we can apply. But sometimes the morphology is quite helpful. So if I have a lung lesion with this kind of morphology, with this palisade, I need to think in metastatic colon cancer. And then CDX2 could be helpful because it's strongly positive, TTF1 is negative, but just I want to call your attention that some mucinous primary lung carcinomas could be also CDX2 positive and TTF1 negative. P16 could be useful in the distinctions of a primary squamous cell carcinoma or a metastatic squamous cell carcinoma from the cervix or head and neck. If P16 is diffusely strongly positive, so this favors metastatic squamous cell carcinoma than primary lung squamous cell carcinoma. This graphic is very interesting. You see in orange that in the future, pathological data, patient characteristics, imaging data is still important, but it will be more important the molecular information, the green, and the available treatment options. Because this is really changed the history, natural history of lung cancer. It's very clear. There are many papers showing, as you can see here in our left in blue, patients that receive target therapy compared by patients that receive non-target therapy or non-treatment has a much better survival. Okay? Patients that have a driver gene that can be targetable have better survival than patients that don't have. So we cannot deny to the patient the study of putative molecular targets. And this is the evolution in lung cancer. We came from the traditional view, from the histology, and now to molecular pathology and to determination of PD-L1. At least there is a minimal panel that I need to study in any non-small cell lung cancer, especially adenocarcinoma. I need to study EGFR, KRAS, ALK, ROS, RET, BRAF, NTRK, and MET, and PD-L1, at least 9 testing targets. So these targets, all of them can be studied in cytology. This table is a table that shows to you the molecular alterations more common and the methodology used to study. This is also in the book that you will have access in the future to this. I will not spend more time here, just to say to you that the way to cover all these genes is to doing next generation sequencing. And this is that we do in our lab. Over all these important genes. 40 to 50% of the cases we have only cytology. But the good news is that any type of cytological material can be used for NGS. So even if the slides were already stained, we can use, what we need to have a sufficient number of malignant cells. If we have, all material can be studied by NGS. So this is the options for the first-line therapy in lung cancer. So these genes that I listed, target therapy, but also immunotherapy. And for example, if the patient has PD-L1 more than 50% positive in the cells, it's a good target for immunotherapy. So in the recent years, more and more papers are start to studying PD-L1 expression in cytology. It's possible to do, it is. We can do in cell blocks, but also in, for example, in exfoliative cytology. Here you see an example in effusions. We can look the PD-L1. And in this paper, they compare with the cell blocks with the non-cell blocks. So if you adjust the immunohistochemistry protocols for the non-cell blocks, we also can study PD-L1 in non-cell blocks. Here you can see PD-L1 on the cell blocks using the same histology standardized protocols, and we use the same score, and then you see the strongly positivity in the membrane. So this is our recent studies with using different assays and different in different types of material, but in the end the results are quite acceptable to use in the clinical setting. One thing that's we need to be cautious when we interpret PD-L1 in lung cytology is that the macrophages. Remember, the macrophages, the alveolar macrophages, are positive for PD-L1. So don't confound these as tumor cells, because they are macrophages. This is the real tumor cells. And sometimes tumor cells were negative and the macrophages were positive, and we need to avoid to call this a positive case. So to conclude my lecture, I say to you that this system, the WHO system, defines 5 categories for reporting lung cytology, each one with a clear definition, a risk of malignancy, and suggests a management algorithm. The key diagnostic cytopathology features of each of these lesions are presented in the blue book. Remember that 70% of lung cancer patients who present with advanced stage, the diagnosis and the classification of lung cancer must be based primarily on small biopsy and or cytology specimens, and that cytology have a good sensitivity and predictive positive value for diagnosing classification of lung cancer, as well as is an excellent alternative to apply molecular techniques for tailoring therapy. So thank you very much for your attention. This is the group of my unity of molecular pathology. So it's a young, very motivated people. And in the end, I would like to invite you to join the International Congress of Cytology next November between 15, 20 that will be held in Baltimore in the United States. And it will be, for the first time, a joint meeting between the International Academy of Cytology and the American Society of Cytopathology. Thank you very much for your attention, for the invitation to be here. And I'm here for your questions. Thank you.
Thank you very much, Fernando. We have stopped your lunch, but as you were live, we had up to 227 participants to the webinar. So this means that this is a really important subject, and it means also that the cytopathologists are really interested in this new WHO classification for lung cytopathology. So if there are questions now, I just want to ask you, Fernando, when do you think that the Blue Book will be out? This year or next year?
So the book is already finished. We are in revision now for the pathological revision. According to the IARC, they are planning for the end of this year. Probably the pancreas book will be launched first before the Congress, and the lung in the end of the year. Okay,
thank you. This is a good news. There have been some discussion on the chat about the inadequate representative, not representative category. As you said, it was difficult to find any total agreement. We have a comment from Franco Fulciniti that is saying that he would propose to call the sample not representative when the clinician and cytopathologists are sure about the correct location of a needle in a lesion that contains only benign cells.
Yeah, I fully agree with Franco. This is I will call the more easy part. For me, the difficulty is when you are in the lab and you receive a specimen slide just with the report. This is common, you know, this is practice in most of the world is in this way. So few of us work in the hospital that you can go to see the X-ray or the CT, etc. But most of us worked in a lab that we receive slides and just the clinical information. No, and I know this is I don't have the answer for this with what is this correct, you know. What I want to say to you is that we need to work on this. So we need to study these cases to see what happened after our report, to assess the risk of malignancy, to bring some criteria that we don't have. So Papa Nicolau Society has a criteria that less than 3 centimeters of the lesion in the lung or higher than 3 centimeters. But I think that this is really, the problem is still there. When you are not seeing the lesion, is again the same problem. No? Between our group, there is many discussion about this. So, for example, more the American side say no. If the clinicians say there is a lesion and I have only benign cells, I report non-diagnostic or insufficient material for diagnosis. But there are other people that say, but if I do this, you know, the clinicians say, I will not send more cytology to you because cells were there. It is not only for lung. We know that's not only for lung, the situation, but for lung is more, I call more problematic because it's not an easy target to sample again. If you have a thyroid, a breast, a lymph node, you can sample again very easily if there is a problem of representativity. But in lung is a little bit different.
Yeah, thank you, Fernando. And I hope also that following the first edition, there will be a lot of paper coming out about the different categories, the risk of malignancy in different categories, so that the second version will be based on more concrete data about all of that. Yeah. So we have another question about molecular studies. If there are any pre-analytical prerequisite for the cytological specimen to perform molecular studies.
So of course that the well-fixed when we talk about molecular studies, is good to say this. We are talking in study DNA and RNA, okay? So for DNA, there is no problem. So DNA, even, we need quantity, okay? If you have the cells there, even if they are not, of course, if you put some strange fixative or something that destroy DNA, it's impossible. But if you do our regular things, for DNA, there is no big problem. But for RNA, there is problem. So the material should be well fixed. But which kind of fixative? Alcohol, methanol, or formalin. So you can use any one of these and it works well for RNA. But if there was bad fixation, okay, if there's too much blood, etc., it's not a good material for RNA. So the trouble is with RNA more than with the DNA. If you use your regular specimen for cytology, because we know when we talk cytology, you are talking about smear, you are talking about liquid-based, cytocentrifuge, or cell blocks. So these 4 different types of cytology can be used for molecular studies, RNA, DNA, since they were well fixed, and since you have number of cells. For me, the more critical is cytology, and we still have problems every day, is with the quantity. Sometimes when you have less than 1,000 cells, really, sometimes you have DNA good, but RNA was not good. So, or as not in enough quantity in this case for the analysis. And then, you know, in lung, Rep, ROS, and ALK, the important is the fusion genes. So we study RNA. So for these 3 important markers, we need good RNA. So if I do only DNA, I'm providing a result that is not complete. Okay. So this is the most important in this. I saw here, Massimo, one comment that if the cell block done from the thin prep, if you can use PD-L1, the answer is yes.
Yeah. And NSLC, non-small lung cancer, NOS can be used?
Can be used.
Yeah.
So it's very peculiar situations that you have. It's clearly non-small cell lung cancer, and you don't have any marker, or you don't have more material to study markers. So you can say this, and then you can put a note. No? Because there is sometimes you have even you have cytology, morphology, but you don't have more material for immune, and you are not sure if this is squamous adeno. You can report like this and put a note that to subdivide you need material for ancillary testing.
Yeah.
If it is not possible to have more material, okay, and you have material enough for molecular, the guidelines say, okay, send this case for molecular. Okay, because in doubt, it's better to study some marker that don't study.
Yeah, there are comments also in the importance of contact between clinicians and cytology lab. And there is also a question about fine needle aspiration biopsy versus the term fine needle aspiration cytology. What is your opinion? Should we use only fine needle aspiration cytology or biopsy as used in US?
Okay, so let's see to the more easy one, that is the contact with the clinicians. This is fundamental. Of course, if you can have these, you must have. I know that's not possible for people that don't work in the hospital environment, but even if you work in a lab, you can have contact with the clinician. So I had a professor of pathology when I was a student, and she always showed a telephone this very old telephone, because I'm old, and say, this is the best friend of the pathologist. And this is true. This telephone is sometimes the best friend, that you clarified a lot of things with the telephone. But I want to draw your attention, because with this molecular studies also, it's becoming more and more important to have the clinician background. For example, we have here in our region, each 15 days, we have a molecular tumor board online by Zoom, as we are doing now. You know, and with the lung, it's just for lung, because we can discuss not only the molecular alterations, okay, present, that sometimes the clinician don't know if it's important, not important, but I use all these sections to say, look, there are few material, the material is not good, you need to collect in this way, and that way. It's like an education process. So contact with the clinicians are fundamental, if it's possible, of course. Final aspiration biopsy or cytology, there is a huge discussion in our group. Many people defend cytology because wants to put different from histology, but also many people defend biopsy because brings to the clinician more trust in the methodology. Because most of the clinicians, when they use cytology, they think that cytology is something for screening, not for diagnosis. And if you see fine needle aspiration biopsy, this is, I can trust because it's biopsy. So I don't have a special, I'm using more biopsy because after many discussions in the book, we need to use in the book fine needle aspiration biopsy. We decide by the majority. So I'm following the majority. This is the reason that I'm using in the lecture in the slide.
Thank you, Fernando. Two more questions and then we will close. Do you recommend ROSE, rapid on-site evaluation, in lung lesion?
I think that if it is possible, you should have. If you cannot go there and you have a good cytotechnician, send the cytotechnician there. The cytotechnician trained is able to recognize if there is material. He or she is able also to separate material for ancillary techniques. I know that sometimes, because the problem of ROSE is the problem of the time that you spend there, we are not reimbursed for ROSE. So if I stay in my office seeing 10 cytologists, I earn 10. And if I go to ROSE, I earn 0. But if you have trained cytotechs, it's good to have always ROSE. I practiced 2 years in Canada and 1 year in Canada, and we, as a cytopathologist, and we perform ROSE every day, from especially lung, but also for thyroid and other organs. And it's a very rewarding. It's very tough, but it's a very rewarding experience, because there in the ROSE you have the contact with the clinician. You can talk with the clinician even about other cases, and you select good material. So the answer is yes.
And last question, in cases carcinoid versus small cell neuroendocrine cell carcinoma on fine needle aspiration of frozen section, can you use the term atypical as a diagnosis?
If it is
carcinoid versus small cell carcinoma.
Yeah, but the atypical, I think that he's mentioned atypical carcinoid. And the recommendation for the diagnosis of atypical carcinoid in cytology, at least they say, don't do this diagnosis. So if it is a classical carcinoid, you call carcinoid. If it's a classical small cell, you call small cell. If you don't have, if we're not sure, you call this a neuroendocrine neoplasia. If it is possible to say low grade, high grade, you can say. But if it is not possible, call this way and say that you are not possible to do this distinction. But the diagnosis, the cytological diagnosis of atypical carcinoid, at least until now, is not recommended. Even in small biopsy is not recommended.
Okay, thank you very much, Fernando. There are a lot of people that are thanking you for this wonderful presentation, and I agree with all of them. So your talk will be soon available on the YouTube channel of International Academy of Cytology. So please check our website to see when it's on, and you can diffuse it to all the cytopathologists. So thank you again to everyone, and again to you, Fernando. It was a pleasure, and see you next time for the next webinar.